This set of slides will cover aminoglycosides. Aminoglycosides, some of the most common ones are amikacin, gentamicin, tobramycin, neomycin, and streptomycin. The one that is least likely to have developed drug resistance is amikacin. Least expensive is gentamicin. Neomycin is sometimes used as an oral suppressant to suppress the normal flora of the GI tract. Most frequently, we see it used to treat ear, eye, and skin infections. Also, we see neomycin used in combination with bacitracin, which will give us neosporin. Tobramycin is actually offered in an inhalant form and treats cystic fibrosis patients. Aminoglycosides bind to the 30S ribosome, and then it inhibits the bacterial protein synthesis. So as you see here, aminoglycosides, and these are ribosomes, so it bonds to those. So basically, they can no longer go through the protein synthesis, and it makes them bactericidal. These are primarily used to treat gram-negative bacteria. You will see them used in combination in order to treat gram-positive, but those are very few. So when you think of aminoglycosides, please think of gram-negative bacteria. The pharmacokinetics and pharmacodynamics, basically aminoglycosides are cleared by the renal system. And the pharmacodynamics, the higher the concentration of the drug, the more the bacterial death occurs. So it's always a fine balance between efficacy and toxicity. So that's why we monitor the peak and the trough, so we can make sure we find the proper dosage. So we're not going too high so they're not too toxic, or too low so it's not therapeutic enough. Also with these medications, there's something called the post-antibiotic effect. And what is interesting about aminoglycosides is they go ahead and keep killing even after the dosage has stopped. So if you look here, the blue line is the beta-lactam, which is basically penicillins. And then the red line is the aminoglycosides. And if you notice, the red line actually levels out and continues to kill the bacteria. Whereas you notice the blue line starts to cheat back up much sooner, so it's doing a lot less killing of the bacteria. So aminoglycosides have that post-antibiotic effect to them. There are many uses for aminoglycosides, but we don't use them as frequently as we used to because we have better antibiotics that have less side effects. So we tend not to use these until we absolutely have to. Again, the oral neomycin we give before elective bowel surgery. It's not absorbed. It just kills off the flora. The main routes are IM or IV or topical. The one exception is that oral neomycin. We talked about the pharmacokinetics and the mechanism of action. Almost always used along with another cell wall synthesizer inhibitor. So a lot of times you'll see these in combination with penicillin. I do want to stress, if you're a nurse mixing up penicillin and aminoglycoside, they cannot be mixed together. It is important to realize, though, in the body, they actually have a synergistic effect with one another. We'll talk a little later about which specific medication is useful in endocarditis. And, of course, skin infections, which is our topical, our neosporin, and UTI and GU procedures. Adverse effects, ototoxicity and nephrotoxicity, neuromuscular junctional blockade, and that comes with high doses, and it's actually a pregnancy category D. I know it has C here, but it's actually pregnancy category D. Aminoglycosides are primarily used for gram-negative rods. Pseudomonas aeruginosa and E. coli infections, and mycobacteria in combination with other medications is used to treat tuberculosis. So the mycobacteria is at the cause, tuberculosis the disease, used in combination with other antibiotics. Streptomycin is used in combination with penicillin G for endocarditis, and it has that synergistic effect. So the penicillin will destroy the integrity of the cell wall, and that will help the aminoglycoside to reach the ribosome and inhibit the protein biosynthesis. Again, the nursing note on this is penicillin and aminoglycosides should not be mixed in the same syringe because they inactivate each other. However, in the body, they have a synergistic effect and actually work together to kill the bacteria faster. Now, aminoglycosides, we had discussed earlier that they do need to have a peak and a trough, so it does depend on the physician and the pharmacy and the patient on which medication and which dosage regimen, whether it's a one-time, whether it's 3 times a day, and whether they have renal problems. So this is just an example of how different aminoglycosides may be dosed. So as you notice, gentamicin is different than tobramycin. The peak and troughs are drawn at different times with different target levels. So just realize this is one of those medications that you do need to have a peak and a trough on. So discussing peak and trough, basically we want to monitor the serum drug levels because this enables the physician to individualize the dose to maximize its effectiveness. So we really want to keep that dose as close to toxic without going toxic as we can, because the higher we keep the dose, the more bacteria that we kill. And then the trough we measure because it's the lowest amount of dose that the patient will have in the system. So the peak is not the time that we give it, the peak is when it's most effective. And peak and trough we will draw on many different types of medications, and based on protocol and procedure at your facility, they will tell you when to draw those and what your goal targets are. So realize here we're thinking IM injection maybe between 30 minutes to an hour after administration would be the peak. IV would be 30 minutes after administration, depending on which medication, which aminoglycoside was chosen. And again, determining whether it's a daily dose or whether it's multiple doses. So the ordering details do matter with this medication. But understand the peak and the trough and why we draw it. So we want to keep the concentration as high as possible in the blood without it being toxic. Adverse reactions we might see are nephrotoxicity. So that kidney damage, we need to make sure that we're monitoring our INO and our renal function tests, which are bune and creatinine. And then use with caution in patients with renal disease, and they may need renal dosages. So they may actually decrease their dose based on their kidney functioning. So these labs we do need to pay attention to and call attention to the physician if those labs are incredibly abnormal. Ototoxicity, we need to assess the patient's hearing before administering these medications. Many times we don't have good data because nurses tend not to really assess hearing until after the medication has been started. So we really do need to get a baseline assessment on their initial hearing before we start the medication. Again, always make sure we draw blood cultures if it's the initiation of any antibiotic. Use with caution with ototoxic meds like loop diuretics. Vancomycin actually not only increases the chances of ototoxicity, but really increases the chances of nephrotoxicity as well. Puts patients at risk for a neuromuscular blockade. You might see signs and symptoms of respiratory depression and muscle weakness, so you need to consider then that maybe they have a neuromuscular blockade. It's almost pretty much contraindicated in patients with myasthenia gravis. because it just increases their muscle weakness. So we all know what myasthenia gravis is, so just make sure that our patients are not receiving aminoglycosides. It is a pregnancy category D. I know in one of the slides in the picture it had C, but it is considered a pregnancy category D. It is teratogenic to the fetus. It actually causes damage on the 8th cranial nerve, just like it does on adults, and many times the babies will come out deaf if their mother has had an aminoglycoside. A special consideration with streptomycin is it could cause neurologic disorders, which include peripheral neuropathy, optic nerve dysfunction, tingling in the hands and feet. Again, just really focus on those ototoxicity with the ears and nephrotoxicity with the kidneys. Nursing considerations, we always want to make sure our patient is properly hydrated with at least 3,000 mLs per day and that they're having normal urine output. So if not, we may need to change the dosage or consider a different medication altogether. We do always need to fulfill the full course, which includes 7 to 10 days, and monitor the peak and trough based on the protocol. Here's just a visual for aminoglycosides, and also always remember that we do need to watch out for superinfections. So anytime that they may be having excessive diarrhea, vomiting, we do need to consider possible development of C. diff. So aminoglycosides, just to review, it is bactericidal. It does prevent protein synthesis from occurring by binding to the 30S unit of the ribosome. The side effects include ototoxicity and nephrotoxicity. It is poorly absorbed in the gut, and as a result, it's usually administered IM, IV, topically, or in drops, ear or eye drops. It is eliminated through the kidney, and it does not cross the blood-brain barrier, but it does cross the placenta, puts the fetus and the baby at risk for that 8th cranial nerve damage, which causes hearing loss. And as with any antibiotic, we do need to be aware of superinfections. So just watching out for nausea, diarrhea that would indicate maybe they have C. diff. Aminoglycosides. Keep in mind these are not used as frequently any longer just because of the adverse reactions that come with them and the interactions that can occur with other medications like Lasix, which Lasix causes a high risk of ototoxicity, vancomycin, ototoxicity, and nephrotoxicity. So we actually have moved away from these antibiotics more and really only save them when they're absolutely needed.